Good evening, and thank you for joining us. I am Dr. Jeffrey Sterling, Brother Dr. Jeffrey Sterling, Surgeon General for Alpha Phi Alpha Fraternity Incorporated. And on behalf of our General President, Brother Dr. Willis Lonsis III, I want to welcome you to tonight's event in the Alpha Phi Alpha Surgeon General Initiative Health Webinar Series. I'm very pleased. Let's go ahead and get our two deputies up. It's always good when we can have a conversation with a couple of our deputy surgeon generals. We have two of our six joining us for the conversation tonight, Brother Dr. Torrance Brown and Brother Dr. Chris Womack, our deputy surgeon generals for public health and healthcare disparities, respectively. So let's go ahead and get them up because a big part of what we're going to be doing this evening is having a conversation. What we've been doing in the Surgeon General Initiative really is to provide you with information and advice that will make you empowered and to become better stewards of your own health. However, that is not the fullest extent of the Surgeon General Initiative within Alpha Phi Alpha Fraternity. A big part of what we are also going to be engaging in is advocacy and development and implementation of programs. And it is our public health and our healthcare disparity subcommittees under the leadership of these two brothers that are leading the charge for how that's going to be happening in the upcoming phases of the Surgeon General Initiative. So I am going to eschew the traditional introductions because I want these gentlemen to actually talk just a little bit about their work outside of the fraternity, which very much lends itself toward the work that is occurring inside of the fraternity. So consider this a grand opportunity to introduce yourself and talk about your work. Let's start with you, Brother Dr. Brown.
Hey, good evening. Thank you, Brother Sterling. Torrance Brown here. I work by day in the federal government with the Substance Abuse and Mental Health Services Administration as a director for the Division of Primary Prevention. Prior to joining SAMHSA, I worked also at HHS in the Office of the Secretary on leading program evaluation efforts for the Healthcare Preparedness Program. And my research focus for my doctoral studies and community work has focused primarily on men's health, particularly boys and men of color, and improving health outcomes.
Oh, I'll jump in there, Brother Sterling. I don't know if you were frozen or not. Thank you. Thank you, Dr. Sterling. I'm Chris Womack, proud to be part of this committee. I've been in the healthcare industry, especially in the pharmaceutical industry, for the past 30 years, working in real world value and evidence in the area of oncology. I've also worked in the area of healthcare policy as well. Outside the organization, I've been focusing in the community for the past 20 years in the areas of healthcare disparities and health equity, especially with men and prostate cancer and general health issues in the communities, and have loaned my talents to go to various organizations to speak about healthcare disparities and issues in the community related to healthcare.
So all of that is to say that these two gentlemen have incredible oversight. Again, let me brag on you a little bit because we always cut back a little bit when we are doing self-introductions. I wanted to see how far you gentlemen were going to go. But in the example of Brother Brown, I mean, this is amazing. Oversight of cooperative agreements, grants, and programmatic outcomes in support of multi-million-dollar federal programs to support communities, hundreds of healthcare coalitions in all 50 states, territories, and freely associated states. That's pretty high. And that's a hell of a lot of responsibility that we want to deploy for the betterment of our brothers, families, and the communities that we serve. And similarly, just the fact that Brother Womack is the Healthcare Policy and Advocacy Director for Johnson & Johnson, you know, that pretty much tells you so much about the scope of expertise that we have available to us. So again, I want to thank you for the work that you've done over what now has been about a year and a half. And we still have a long way to go. But I'm so pleased to have you both here because I'm very proud of the work that we're about to discuss and about to perform on behalf of the fraternity. So let's just jump in. And I'm going to defer to the two of you, and then I'll just jump in behind you. But I actually want to start with a general discussion about public health. And for the individuals that aren't in any of the health sciences or public health fields. Why don't you, Brother Brown, just describe a little bit about why this is important and what the field's all about?
Sure. Public health is defined as the science of protecting and improving the health of people and their communities where they live, learn, work, and play. So this encompasses a large swath of areas and activities. I know most people are familiar with the public health strategies that were in place for COVID, the mask mandates, the vaccines, but also thinking further beyond that to seatbelts and fluoride in the water. So really protective measures that are intended to improve health and protect health is what we're talking about when we talk about public health.
Okay, very good. And so, Brother Womack, why don't you take that same swing at what healthcare disparities are and why they're important?
Thank you, Brother Sterling. Just a small correction. I've moved from the policy role and focused on real world value and evidence and oncology. And with that, I'll just give a small disclaimer to let you know the views expressed in my independent thoughts and does not represent those of my employer. But to go into your discussion, healthcare disparities are just a very broad topic and has really surfaced based upon the social issues that we've been facing today. But these healthcare disparities have been going on for some time now and have been researched some time. The disparities you want to look at are the comparison of various communities, meaning how one community is being cared regarding healthcare and how another one is being treated as it relates to healthcare as well. And not only with those disparities, but how also the social environment plays into those disparities. So it's not only what they're receiving from a healthcare perspective, but also how the environment might play into that mix in terms of creating those disparities. For example, and I won't go into too much detail, there was a study some time ago trying to figure out why kids in the Harlem area, and this had to be about maybe 10 or 15 years ago, were being in the emergency room for multiple times for asthma attacks. But when they started looking at the environment, they noticed the buses and the pollution in the area were creating that aggravating issue for those kids. So that's why they were winding up in those areas so often. So if you go out to a suburban area, you would not see those buses with the fumes and things of that nature creating those aggravating conditions. So that's just sort of a high level discussion, understanding of healthcare disparities.
Thank you. So let me slow this way down, because I think that what the two of you just did in a matter of minutes is to talk about something that typically we could be discussing over a few days, if not weeks. So let's just get into the weeds so that our viewers actually understand what it is we're talking about. And let's just start with public health in general. You know, the bottom line is, forget what you heard. Public health is the reason why we're still here. I am here to tell you as an emergency physician and a public health professional that so many more lives have been saved through public health initiatives than by the practice of medicine. It is so true that an ounce of prevention is worth a pound of cure. So for example, the reason why the single biggest improvement in life expectancy in the last century was actually the ability for us to drink purified water. So consider that, if you will. For centuries, the number one cause of death worldwide was dehydration and due to diarrhea. And much of that came from the way in which individuals had to drink water that was filled with various diseases. So the simple act of public health that allowed us to drink water that was free of diseases, free of other things that would cause diarrhea and lead to dehydration and superimposed infections, etc., is a public health consideration. And again, whether you're talking about programs that have reduced the rate of smoking, whether you're talking about the application of the mandates of seatbelts, and of course, as is all the rage, it was also mentioned earlier that the notion of vaccinations. You know, there was a time where things like polio and smallpox haunted us in a much greater fashion than COVID-19 did. But again, these types of programs are why public health initiatives are so important and actually so very effective. So that's that. Now, on the healthcare disparities side, it really is pretty fascinating, because I always begin these conversations with the notion that the greatest healthcare disparity is the disparity in life expectancy. So depending on if you're a white woman and a black male in the United States, there's a difference in how long you can expect to live of about a dozen years. And you probably already know who gets the short end of that stick. But even as you compare between women to women, black woman to black woman, and black man to white man, blacks still have worse outcomes than the general population, and certainly white Americans. If you actually looked at the top 10 of the leading causes of death in the United States, blacks actually are disproportionately represented in 9 of those top 10 causes of death, with the exception being suicide, for which we're overrepresented when it comes to homicide. So these are the types of things that represent disparities. Why are we not able to live as long as other members of the population when you control for everything else and allow for the fact that these aren't things that are attributable to simply being a different ethnicity? So now, if that proves to be the case, the challenge and our charge become, how do we work around these types of disparities? What are the causes of these disparities? And again, what can we ourselves do to improve our own situations? And this is why the Surgeon General initiative within Alpha Phi Alpha is set up in the way in which it is, because we want to bring the experts that we have who are members of the fraternity and to use outside expertise in a collaborative way to assist our members, their families, and the communities that we serve. So let me bounce it back to our Deputy Surgeon Generals to talk about the work of their committees. So once again, let's begin with a public health conversation, and let's actually take as much time as you'd like to talk about the Alpha Phi Alpha Public Health Subcommittee and the work that you've been doing and the work that we can look forward to you doing in the upcoming months.
So yeah, absolutely. So as you just mentioned, we know that there's both an appetite and critical need for health-focused discussions, actions, activities, and interventions that impact men and their families. As you mentioned, the life expectancy for men is way less than women. And we also know that according to the CDC, the age-adjusted death rates for Black men Black men are dying at faster rates than other races, at 1,399 men per 100,000 population in 2020, compared to white males at 985 men per 100,000 population. Another fact that we know that we know related to public health is that we need to borrow from existing social and public health frameworks to ensure that we are successful on the Public Health Committee. And one promising framework for collaborative work to improve outcomes is the Community Coalition Action Theory, developed by Butterfoss and Kevler in 2002. And the goal of the CAT, which we call the Community Coalition Action Theory, is to complete analysis of the problem, data gathering and completing needs assessments, developing a plan of action, implementing and developing solutions, and achieving outcomes. So some of the steps that we've taken in the Public Health Committee, we started with doing a pulse check of the committee membership on April 25th through 29th. We have over 20 members in this Public Health Committee, and there were 5 top health topics identified from the committee survey: mental health, aging, diabetes, prostate cancer, hypertension. And one of the number 1 committee objectives was to serve as a health resource for local chapters. And our population of focus, of course, will be the local chapters. And so what are we hoping to accomplish as part of the Public Health Committee? Our charge was to identify which health topics should be pursued by the committee and to provide identified technical assistance to local chapters and to identify potential opportunities for the Public Health Committee to partner with the Alpha Phi Alpha Fraternity Incorporated Health and Wellness Committee. So that's a general overview of kind of where we are at the moment and sort of the steps that we've taken to sort of move the needle forward.
Can you speak a little bit about what some of the results were of the survey?
Yes. So as I mentioned, the top health topics that were identified included mental health, aging, diabetes, prostate cancer, hypertension. And there were a number of populations of focus that were raised, but the chief population of focus for the initiative was the local chapters. It was also raised that maybe we should look at men in general, men in the communities, but the predominant population of focus was the local chapter. And also there were a number of organizations that were listed that the membership thought might be helpful to partner with either nationally or locally in terms of pushing the public health agenda forward for the committee. And some of those included the American, the National National Dental Association, National Medical Association, and as well as American Diabetes Association, and a number of other large nonprofit organizations that focus in the health space currently.
Okay, so again, to the audience, a fundamental way, you gave a quite elaborate and accurate description of public health, but a very simplistic way to look at it, and what helped me transition is that as a physician, I was responsible for the care of individuals, 20 at a time, and most of they show up in the emergency department on a bus. But public health is actually the care of communities, and it is the development of strategies that impact outcomes for communities. So in our Alpha community, and in the African American community, and in the greater American community, it is important for us to look at certain things like men's health as a global consideration, to look at what are the 10 most common causes of death amongst the general population, and amongst the Black population, and amongst the Black male population. Because in order to get the biggest bang for your buck, if you will, we need to strategically address those items that are at highest risk. And that is what was borne out in the survey. The things that are of importance to you are the same things that statistically we should all be concerned with. So it's important for us to go through that, just so you have an appreciation that when you are concerned about something, we are actually talking about it, and we are actually developing strategies to get at those things. Now, you've seen some of that in the first two phases of the Surgeon General Initiative. You're sitting in a webinar now, which was the rollout of phase one. Hopefully you've gone to Sphinx TV and looked at the dozens and dozens of video blogs that we've uploaded. We do about 3 a week. They're 5 or 10 minutes each, and it's just a video library for information that you may want to have on your, not favorite, but most applicable or interesting topic to you of health, public health, or science. And, you know, these things that we're about to talk about later in this webinar now are the things that we're looking at doing. So that's a pretty good discussion of the overview of the Public Health Committee. Now let's talk about the same for the Healthcare Disparities Subcommittee. Brother Womack?
Sure, thank you, Dr. Sterling. The Healthcare Disparities Committee has been hard at work, and we've been focusing on 3 key areas, or what we call our 3-prong approach in terms of talking about healthcare disparities itself. Meaning, first one is to inform. What do we mean by inform? Explain healthcare disparities. What does that mean in totality? But also to drill it down to what does that mean to me as an individual? The second part is educate. We have addressed key areas related to health disparities, such as access to healthcare. What do those numbers mean when they say we're leading in diabetes and cancer and heart disease? Why is this happening? And what can we do? The third part is action, where we need to be involved in the process and what can we do or control to a certain degree. Some think that, you know, we have no control over this. There are certain areas that we do have some control over, but to a greater degree we don't, but there are some smaller things we can do. The Healthcare Disparities Committee has been sort of, I call it a revolving team with people loaning their talents, coming in and out the committee. And one of the things that we've been focusing on currently has been the one area we really need to look at is today we're working on important projects focused on legislative items that impact the community, the population in general, but have a multiplier effect in communities of Black and Brown people. A team consisting of Dr. Ulysses Burley, Dr. Lydell Letsom, Dr. Brian Stone, and myself have been reviewing key legislative items that Alpha Phi Alpha can add its voice to, along with other groups to assure these bills that might be languishing on someone's desk move forward, but also some of the bills that have been passed that we need to know what do they mean and how can we use them to our benefit. This is even more important seeing that we're in an election cycle that will impact our community as a whole. We will provide a document to our general president working with Dr. Sterling with recommendations on what we think the fraternity's approach should be, how we need to support various pieces of legislation, and how do we educate. Just to give you examples, and please hold me back, Dr. Sterling, because I know sometimes I get on my platform and I don't know how to pull back. One example is Mama's Act, which is HR 3407. And this supports women during pregnancy. Every year across the United States, nearly 4 million women give birth. About 700 women suffer from fatal complications during pregnancy while giving birth or during the postpartum period. And about 70,000 women suffer from near fatal partum-related complications. Mental health parity, as you alluded to, Dr. Sterling, mental health parity needs to have the same weight as someone going in for a broken arm versus someone walking in saying, I'm really depressed and I need help. They need to be weighed the same. So hence mental health parity. Surprise Medical Billing Act, which went through, I think, in January 1st of 2022, making sure you don't have those surprise notices on your bill. Meaning, I saw Dr. Who, when, and he's charging $3,000 for what? I never saw this doctor. Understanding how these things occur and how these impact how we receive medical care. There are numerous things that we're looking at and combing through that we're going to bring forth to the Brotherhood and actually hope we take some action on some of these items. We don't have to do everything because we know we don't want to eat the whole elephant, but maybe there are one or two things we can get our names behind to say, hey, Alpha Phi Alpha stands behind this.
That's brilliant. Thank you. I actually want to stay on this conversation and get into the weeds because I want the brothers, I want to take advantage of this session to actually inform our audience about things that comprise concerns as it relates to healthcare disparities. So there are a couple of things. So let's just talk about how healthcare disparities actually arise. And we are literally talking about outcomes. What is out there that produces poorer outcomes for one group of individuals or one community relative to another? So as these things go, a word that everybody should be familiar with, because we're going to be talking about it a lot, and our colleagues in public health and even in medical care and scientific care are very interested in the notion of social determinants of health. Because you just don't pop up one day and develop diabetes. There's a lot that happened along the way that made you a greater risk and allowed that to manifest itself. So I'm going to open this up to both of you since you both deal with this notion, but let's just actually talk about it in the broadest possible terms as to how social determinants of health actually produce healthcare disparities.
Sure. I could jump in.
Oh, sure. Great.
So certainly thinking about social terms of health, we're thinking about education. We're thinking about economics. We're thinking about environmental factors. How those factors, for instance, we know that folks with greater education, according to the statistics, have better health outcomes or have a better health status. And we know that that folks who don't have access to education also have poor health outcomes and health status. And so the same is true with finances. If you don't have access to a good job that provides a decent wage, your health outcomes might be a little less than those who have a job that have higher wages. So there is this seesaw effect where you see those folks who have the less aspect of the education, less aspect of the finance, who don't have sidewalks in their communities. The environmental piece, you can't walk in your communities to get the physical activity that you need if you don't have sidewalks in your community. So all these factors are social determinants or structural factors that impact the way health sort of realized.
Okay.
And, sure. And just to add on where Dr. Brown left off, my dissertation focused on African American men and why they do and don't have prostate cancer screening. And when you look at the issue, just in that particular, but and just in totality and social determinants of health, is twofold. One is access, as Dr. Brown eloquently spelled out, but the other part is the education and acting on that as well. To give an example, we just finished a NBA championship where Golden State Warriors won. And I guarantee you, I can walk into most barbershops in the area and they'll tell you how many assists Steph Curry had, how many points he had, rebounds he had, things of that nature. But I can ask them, do you know what your last PSA number was? That might be a pause. They may not know what a PSA number is. That's awareness and education. The other component is, are they having these discussions when they go to their family care physician? And I'm talking on multiple sides. There are people who have health care who do not have these discussions with their doctors because maybe their doctors don't understand how to have that conversation with them. For example, a Black man walking in there and saying, hey, I may be 40, but my father had prostate cancer. My uncle had prostate cancer. Another uncle had prostate cancer. I'm overweight. You have all these risk factors, but maybe they may not do a PSA or a digital rectal exam on, and we as Black men, we treat the doctor's office as a 5-minute trip. I want to be in and out of here as quick as possible. So sometimes we're not using some of the resources we have available to take charge of our health, but also, as Dr. Brown mentioned, sometimes it's just access. How many offices are in a area near you, especially in rural communities where you have a greater distance to travel? In more metro areas, maybe you have transportation there, but maybe the doctor doesn't understand you or hear you, which brings up another topic in itself in terms of the reduction in number of Black male physicians in our system. So, but I'll pull back from that, brother, Dr. Sterling. But that's one of the things to take into consideration of is just that twofold approach: our understanding and education, and also our access.
That was outstanding. Thank you, brothers. Again, let me back up, slow this down, and repackage it so brothers can fully digest this. We're talking social determinants of health. And by the way, my dissertation was actually on the implementation of strategies. I actually built what were called health and human service centers, because you can't dissect one away from the other. And that was 30 years ago, my goodness. And here we are now talking about that exact same construct. So social determinants of health are simply the conditions in the environments where people are born, where they live, where they work, where they play, where they worship, and how they age. That affects a wide variety of health conditions, good and bad. So let's just talk about some of those considerations real briefly, and you've mentioned a few of them. Economic stability. If you don't have a job, you can't afford to see a physician. You can't afford to buy medicine. Education. If you don't have a requisite amount of education, let's just say if you don't even speak the language, then how can you read a prescription bottle to know what medicines to take with the right frequency and the right amounts? Access to health and healthcare. We talk about food deserts, food islands. We also talk about healthcare deserts and healthcare islands. As luck would have it, certain communities that are disproportionately represented by minorities are very often wanting to have physicians in those communities. And all physicians are not created equal. Even when physicians may exist in a community, they may not be culturally sensitive or culturally specific in a way that produces better healthcare outcomes. Imagine, if you will, what happens if your neighborhood actually causes disease? And I'm not just talking about because you're more likely to get shot or stabbed, but what if you're living near a power plant or by a smokestack in an industrial area? These are things that literally increase your risk of cancers. And there have been movies like Aaron Brockovich, etc. These are very real things that are determinants of your health. And of course, Social and community context is another consideration. What if you're in a family or in a religious community that does not allow you to get blood transfusions, and there's a disease going around that happens to require such a thing? There's so many ways in which social determinants of health exist. And in order to really produce healthcare outcomes that are better, you need to understand the culture and the environment that we existed as a means of getting at that. And so that is where we are now, even inside of the Surgeon General initiative. We are doing a deep dive on these considerations. As Brother Womack talked about, we will be developing policy recommendations for programming inside of the fraternity and for advocacy to our legislative bodies. You all good? You want to add anything on that? All right. So, as Brother Dr. Womack suggested, this is where we always have to point out, and I began to touch on it just a bit, that there is a public health premise that has long been demonstrated to be the case. It's very much a FUBU principle. Simply put, better healthcare outcomes in the African American community have been demonstrated to be better, and this is actually true within most diversity communities, when that care is being delivered by culturally sensitive and culturally specific individuals. Okay? In other words, if you have a Black physician and you're Black, you're probably going to have better healthcare outcomes. Now, again, you may bristle at that, but it's pretty fascinating. And I know if there are ladies listening, there are a lot of people who always shake their head at this, because it is simply a measure of fact that infant mortality and maternal mortality is directly related to the race of the physician that's taking care of the patient. And in the example of African American women, the number is somewhere about a 30 or 40% higher risk, all things being equal. There's a 30 to 40% higher death rate if these women are being cared for by Caucasian OB-GYNs as opposed to African American OB-GYNs. This is just a fascinating construct. And I bring this up, gentlemen, and you can comment as you will, to point out that there has long been the need to get kids involved in STEM programs, to get them involved in that pipeline, to get them interested in the health sciences, to produce more physicians, nurse practitioners, physician assistants, hospital administrators, public health professionals, executives, the whole 9 yards. As some of you know, back in 1989, I actually created an organization called the Minority Association of Pre-Health Students, which is now on about 300 college campuses across the country, which was meant to be a pipeline, which is a pipeline organization for that very purpose, but it's never enough. And before I toss it back to you, gentlemen, I actually want to point out one additional concern about which we should talk about. A generation ago, the constitution of medical students who were African American was about 80% male and 20% female. Today, that number has entirely reversed, such that only 20% of the current crop of medical students are actually Black men. So there are significant ramifications for that, but what all of this points out is that we have work to do, the royal we and the general population, as well as we within Alpha Phi Alpha, to implement policies and create programs that incentivize our brothers and individuals in general to participate in the health sciences, to get in the pipeline, and to become healthcare professionals. Jump on in on that, gentlemen.
Sure. Dr. Sterling, I want to add a story to what you just mentioned that was very important about talking about those who are providing care to understand the culture of those that they're treating. And this is a quick story. I was at a conference and I was talking to a dietitian I know, and it was an interesting conversation where they said they were working on this gentleman's diabetes. They just couldn't get it under control and couldn't figure out. And she was working on a diet. And when she talked to him what he normally had in the day for dinner, he said, I had plate chicken, rice, beans. And he said, okay, rice is a lot of carbohydrates. So she said, I want you to cut your rice intake in half. So he did. but his A1C was still crazy. And then when the dietitian asked, said, can you show me what you actually consider half? This gentleman came from the Caribbean. So if you come from the Caribbean, your plate is mostly rice. So half of that is a good general portion on your plate. She did not understand that. And she said she felt so bad about that. And she was a white woman. And she said, I have so much more to learn. I have to start really understanding how to peel back that layer. So that goes back to culture as well. If you don't understand what that diet intake is, how can you really help those individuals you're trying to care for? So that was a very interesting conversation and plays directly into what you were saying about having people who understand the culture as well.
You bring to mind, since we're just chatting here, you bring to mind the clumps, and that famous scene of the clumps at the dinner table. And that always is a topic that I'll bring up in the context of people saying, diabetes runs in my family. Well, people need to consider that as a culture, maybe the reason why it runs in your family is because you have a common individual who is serving the food to everyone in the family. It's not a genetic consideration as much as it is the fact that you have unhealthy eating habits that the entire family shares, which predisposes everyone in the family for hypertension and diabetes. So yeah, cultural sensitivity is an issue, and it actually represents a challenge for those of us who would like to transform the way in which our community eats. Because some of you probably heard me say this before, the way that we eat now is not at all consistent with how Africans ate back in the motherland. What we are doing here in America is an evolved post-slavery diet, where we have glorified the scraps that were given to us because slave owners knew not to eat the things that they didn't. And here we are today, still engaged in those same eating habits, and we swear by them. But that's the challenge, and we'll get there. But it is going to be transformative, and a lot of it is cultural, and we'll have to address it from that angle as well. Brother Brown, you have anything to add on that?
I'll just add, to the conversation around the medical, increasing the medical doctors. I think that I did my dissertation on boys and young men of color, specifically on President Obama's My Brother's Keeper initiative. So I looked at different cities to sort of see how they were implementing these 6 strategies. And one of those, some of those strategies, including starting early with our young men, making sure that they have the tools that they need to be able to thrive. So we have to start there with starting early with reading, and then also give them exposure to some of the health professions early on. So I think those are some key factors that I think would be very helpful and impactful, and sort of making sure that we sort of keep the pipeline strong, and also making sure that we have strong mentorship. I also be very important and critical, I think, to sort of making sure that we steer our young men toward disciplines that are STEM or health and science related.
Yes, it is a laborious life, but it is so worth it. And the ability for us to control our own destinies is something that, as a community, we can't take for granted, and we should take ownership of and steer our best and brightest to continue to participate in that way. So I've enjoyed this. I just want to say again to the listening audience, I hope you've understood what it is we've been talking about and why it is important for you to continue to offer your voice. We are not looking to talk at you. We are looking at being responsive to your needs, to your family's needs, to your community's needs. And as such, we need your participation. I think that both of these brothers have pointed out, and this is a beautiful thing about both of your subcommittees, is that there are individuals on these committees that aren't necessarily in the medical, public health, or scientific communities, because there's role for all of us to play in contributing to the thought process about how to affect change inside of our communities. So I want to continue to invite the brothers to participate, to ask questions, to suggest topics that need to be discussed across the entirety of the Surgeon General Initiative. And I think that you are going to be pretty excited because there's great work coming from both the Public Health and the Healthcare Disparities Committee that will result in programming and advocacy efforts on behalf of the fraternity. So let me just yield the floor to you gentlemen one more time and let you offer any closing comments from your committees or thoughts that you have. Let's start with you, Brother Brown.
Sure. So we've talked about the survey that we just completed. That we're going to be embarking upon a journey, and we're going to need your support and your engagement, your input. We have a number of strategies that we want to put forth. One strategy is around community context. So we know we need to identify what are the specific needs and opportunities, what are the top health concerns for brothers regionally at the chapter level as well, how do these concerns align with national data, which national and local organizations are currently working in this space, and how do these needs varies across the region, which is a critical piece about the community context. We know that when you've seen one region, you may have seen one region. Each of the regions may be different, and the health concerns may look differently. So we need to identify what those are for those specific regions. The second strategy is around engagement. Again, how do we increase brotherhood engagement and participation? How do we engage each of the committees of the Surgeon General's Initiative? And how do we engage each of the regions and the regional vice presidents and engage in the chapter level, either via focus groups or surveys or key informant interviews or just informal discussions, just really getting an opportunity to get some buy-in and feedback. And then identify what the shared resources are, and then finally implementing the strategies. What actions can we implement that will result in changes in practices? And what actions can we implement that will result in changes in behavior? So that's our end game, and that's our strategies that we'll put forward for the next few months moving forward. Thanks, Brother Sterling.
One thing you didn't mention that I'm going to jump in on is that we actually are very desirous of getting in the hands of brothers pieces of information, maybe 3x5 index cards that are wallet size that empower them. That's, on some of the major public health initiatives, what to do with stroke recognition, heart attack recognition, emergency items you should be keeping. So, these are also big public health initiatives that will be done in conjunction with our mental health, dental health, family health, tropical health subcommittees as well. So brothers can also look forward to that. But you're entirely on point.
Yeah, Dr. Sterling, I'll just add to that too. The health and screening guidance, we'll be coming up with that.
Yes.
As Sterling just mentioned, and also any program guidance checklist, really a step-by-step planning tool for the implementation of public health programs designed to aid the regions and the chapter related to health programs. So those are also on the horizon.
Exactly. I definitely wanted to get that out, that the regions don't have to reinvent the wheel every time. We will be coming up with guides as to how these things can be done in a way that represents best practices. Thank you so much again. And Brother Dr. Womack.
Sure. Thank you, Dr. Sterling. I just want to repeat what our focus is. And then I have another part, which is more of an appeal. That one of which is that I mentioned three-prong approach: inform, educate, and what is the action? They all happen in sort of a cycle, and you have to keep running the cycle, because as you learn more, you act on more, and then as you inform more, you educate, and it keeps running in a circle. So we want to make sure we don't stay in an area where we're just giving out education, but there's no type of action or anything behind it. With the Healthcare Disparities Committee itself, you have brothers who are giving their time and their passion to this because we believe in our communities and we believe in you who are listening to us, you who are going to talk to other brothers and talk about what we're doing. No one has any agendas. We want our communities to be healthy. We want to provide the tools that are there. And the brothers on the committee and those who have donated their time, and you can bring your time to this committee as well, are willing to invest in that with that sweat equity to ensure. One thing I've learned, and growing up in Southwest Philadelphia, I didn't come from the best of circumstances and never believed I would be at this point in life, that someone told me that as we go through life, we go past a well and someone dips in there and gives us something for our journey. When we come back along that other side of that well, we have a responsibility put in there what we took and add for others coming along the other side as well. This is what this committee does. We put back in this well for others to take part of so they can lead healthy lives. So this is me on my platform. This is me with my plea to people. Brother Sterling knows I do that. But I really believe in that, and we invest our time and energy. So thank you.
That's fantastic. And I just want to follow up by pointing out that this is an all hands on deck proposition. We're not going to transform the health of our community without the help of you. What we're attempting to do is to empower you to be a better steward of your own health and to give you the tools to do the same for your families and your community. You have to become engaged, you have to become informed, educated, and take the actions that are being recommended. We don't want to wait until the point that illness presents to begin these conversations. We don't want to have brothers, your families, and members of your community lost, and then we lament why these things had to be this way. I'm here to tell you that they don't. And we're being proactive in this. We need you on the committees. We need you participating in programs like this to get an understanding of what needs to occur. All hands on deck. We will continue to get this done together. Join us again in 2 weeks for the next Surgeon General Initiative webinar. Yes, it is hot, and we will be having a hot topic. Specifically, we will be talking about heat safety as well as pool safety. So again, on behalf of our General President, Brother Dr. Willis Lonzo III, I want to thank you for joining us this evening. God bless and good night.